It allowed me hope, and it allowed me to connect with people again because they didn't judge me, and they took me in when nobody else wanted me. I was okay in harm reduction. Nobody kicked me out of harm reduction, right? I didn't even know it was a program. And if you shut down that harm reduction, you are shutting down that population. And, even if you don't care about the people dying in the streets, I think you care because you don't want to live in a city where people are dying in the streets. You're talking about kids finding needles in playgrounds. Well, if you take away the places that they can use substances, they're just going to use the substances in the playground. So you're cutting off your nose to spite your face in these situations. So I think it is just super important that we really think about what we're trying to accomplish here when we start closing down programs that can provide options. And all these programs are predicated on the fact that there should be, as you spoke of, a vehicle to get treatment, a vehicle to get well. Well, we're not there yet, and that's the big problem. 9 out of the 10 patients that want to go into residential care that day can't get it. When you're connecting with someone else that nobody wants or they feel nobody wants, it's a visceral connection, and you want to try to help.
We are upset, and we're upset because, we work in this field, and there's a lot of things that are going on in the news that are just not helpful. They don't describe what the problem is. They don't describe how people are interpreting it. They misconflate this. They're comparing. It's even worse than apples and oranges because at least both of them are fruits, right? Like this is like it's very uncomfortable what's happening, and we don't know how to have a meaningful voice and impact just so people know what's actually being discussed and argued. And it's very, very tough. It's at the point where it's like even healthcare providers do not know the difference between A, B, C, D, and E. And these things are nuanced. And the reason that they're nuanced and they have to be nuanced is because different things are going to work for different patient populations at different times in different environments.
Absolutely.
And if you have this blanket statement like people are dying, you can't stop these programs, like, how are you going to help any? Because whatever we're doing right now, and I don't have to say this the right way, JP, we are not helping to the level that's needed.
Right. Absolutely.
The death rates are going up and up and up, innovative program after innovative program. And I don't know, maybe it's the drug supply. Maybe there's no way to catch up. There's new drugs, new analogs. The high is too much. Maybe it's poverty in housing, systemic, whatever that's going on, where there's nothing that can get people out of that sense there. Maybe it's the after effects of COVID with the extreme social isolation. And once it starts and normally, like when you think about people that use drugs, right? You think that like if they all start dying, they'll die, right? But they don't. Like there's always these new people that use drugs that are just there to add to the people at risk of overdoses, right? And so we're upset. We don't know what to do, and that's why we're doing this. And every time that we do an education talk, you always bring up, I don't think anyone knows the difference between these terms, yes. And you always try to get us to talk about it. I'm like, we talked about it a year ago. You're like, the terms have changed. The terms have changed.
Yes.
And it's in the news, and nobody knows what's what.
Yes. So I've just got a little clip here. It's hard to watch. It's just a little bit of the politics in our country because we have a lot of folks from the South and other places in the world. I just wanted to give everyone a taste, and I'm sure you'll never want to go any deeper into Canadian drug policy, but this is a sort of a level of the rhetoric. It's kind of hard to watch, and we got two people talking over the heads of each other.
While the Prime Minister has sent inflation for gas, heat, and groceries soaring, there is one product that's actually come down in price: powerful opioids. The Prime Minister has spent $100 million on so-called safe supply. One Global News reporter went into the street to find out where all these drugs are going. Turns out they're being resold to other addicts in order to raise the money to buy deadly fentanyl. Will the Prime Minister cancel the dollars for drugs and instead put the resources into treatment for addicts?
The Honourable Minister for Mental Health.
Mr. Speaker, we are pretty fed up with this fight against evidence-based programs that actually are saving lives. We cannot allow the Conservatives to take us back to the failed ideology of the past
no common sense. The evidence is seen in the tragic faces of addicts who lie overdosed on the pavement in the downtown east side of Vancouver, where after this Prime Minister spent $100 million handing out free drugs to addicts, he has led to a 300% increase in overdoses. Will he stop giving dollars for drugs and instead follow my common sense plan to put the resources into treatment and recovery to bring our loved ones home drug-free?
The Honourable Minister.
People are dying. Save 46,000 overdoses have been reversed in safe consumption sites. That member says that he will stop that. I want him to speak to the parents of the people that would have been lost if there weren't safe consumption sites and safer supply. This is ridiculous.
Very passionate on both sides, I'm not a political person on this. Full disclosure, I voted for each one of those parties once in my life, and both of them discouraged me. But just off the top here, there's a couple big things on this. Is that they're talking about evidence, for example, evidence on these programs.
Yeah, I mean they're basically based on satisfaction scores, retention in treatment and care, reduced emergency department visits, but they're not looking at whether or not there's diversion. They're not looking at the impacts of it. They're not looking at
there's no double-blind studies happening here.
No, and then they could have done them, right? Well, they couldn't have done double-blind studies, but they could have done like stage-wise rollouts. They could have compared certain regions where the access was there versus where it wasn't. But the point that I think is probably more important, and you may not know this if you're watching this, but we saw this video a second before, right? We saw it like about 30 seconds or maybe 5 minutes before because I forgot to do the recording thing. And you were visibly upset the first time we saw it, and you're visibly upset the second time we saw it. And I was not visibly upset. And I wasn't visibly upset because I'm used to these people yelling about this stuff. I've heard them argue about things that I know a little bit about, in terms of the addiction stuff. And they're talking, whatever they're talking about doesn't make sense. But the look on your face was very interesting to me because I've never seen you visibly upset, right? And I saw it in your eyes, right? And I don't know if it's because these are the people that have the most power in terms of policy. These are the ones that are supposed to be taking care of the most vulnerable, and they don't even understand the issue. I don't know what it was. Maybe it's because of your own personal experience. Maybe it's because of the place where you've worked, where people are dying. We'll see people bring our A game to it, and we can't keep them alive. But I just think it's interesting how this is hitting at you, and I think that there's something in there. And I think the one thing that will be very, very important is what we talked about earlier, where just getting clear definitions of all these things.
Right. Sorry.
No, but it's hard to see you because you've dealt with so much yourself. You've seen so much suffering and death yourself.
Yes.
You've been at tables where you're speaking the best that you can, and sometimes it feels like tokenism. Sometimes they include you in the ideas, but it's very rare that the breadth of your knowledge is applied at the end, right? It's almost like you're nudging it over a little bit, but I've not seen that level of discomfort in watching people speak.
Yeah, it's tough, right? Because I want to be part of I want to be part of solutions, even if it's incrementalism. I want to be part of solutions, and you don't feel that those two people are going to agree on much. Is that fair? It feels like they're apart.
They will never agree on anything.
Right, and that's the frustrating
part. So you've been to tables where they can actually come up with a resolution. Now it's just like nothing's going to win.
Right, because
you almost have to wait till another election, or who knows?
I don't know what you have to wait for. But in fairness, so we did critique one side of it, but we also should bring into the other side of that. So he's also oversimplifying this to say, okay, well, the federal government paid for all these drugs, and as we know, the federal government doesn't pay for drugs. They support programs. They put some grants in out there. They may have smoothed the surface on some of these policy pieces, but it's a provincial decision. So it's not like it's not like as he said, Trudeau, our prime minister then and now, pushed some button and paid and gave all these drugs to everyone. That's a provincial thing. So again, it's both people, sharing some kind of misinformation. And one of the points that I want to build into, because this is what we want to talk about, is because in Ontario, our government has made an announcement they're going to close most of our safe consumption sites. So, regardless of how that sort of sounds, I think it's important to note because even the minister said, about the safe consumption sites are saving lives. Well, the point from the opposition leader, the Conservative there was, I'm talking about safe supply. And so even the minister has conflated these two things. So I think there's this kind of political vacuum there, or that now, something that's controversial, which is safe supply. It's a controversial program. Politically, it's a controversial program for sure. And I think even in addiction circles, it's very controversial for the people we work with. So to say that, closing these safe consumption sites, people think, oh, well, safe supply is a horrible thing. And, and I've seen that. I've been at a table where physicians, working with physicians who are advocating for this policy. It's like, well, it is a hard sell, these safe supply. And I'm like, whoa. Safe consumption sites don't dispense safe supply. Names are similar, but when you have the minister doing it, that's where it gets kind of complicated. So looking at this first slide here, we're going to define what safe consumption sites are, right? What are they closing? So they're closing, these are legal spaces where people can use drugs that are their own drugs. They're not supplied by anybody. They're not, we don't sell the drugs. We don't give the drugs. So that's what they do. So these places help prevent and reduce public drug use, right? That's their...
Like don't some of them have like family doctors there or prescribers there, or are they completely separate?
They're completely separate. They're completely separate. Yes, there's
maybe like in the same building, maybe.
Yeah, perhaps, but they're not.
But not the actual area that's designed for the safer consumption.
That's right. Now, the biggest factor, the one factor that I think nobody gets on this, which is so important, is the level of primary care that's given to inside these safe consumption sites. This is huge. And
so there are primary care providers.
Absolutely, there are primary care providers.
At the safer consumption site.
At the safer consumption site. So I was fortunate enough to volunteer at a safer consumption site in 2017, and you went and visited me there once. And it was
that was in the overdose prevention site?
Right. Which is a safer, yes. So not to get too deep into the weeds of this, but an overdose prevention site is essentially a safer consumption site, but it's a temporary space, right? So yes, that's where you visited me. There were 2 tents out in the park, and the lady I helped build the tent for, I don't have any problem saying her name, Erin. She's just an absolutely wonderful nurse there, and she gives. She is still so from the overdose prevention. She's the same nurse that is now working in the safe consumption 8 years later. So she's built this wonderful community of practice where for this whole population that catchment area serves, they trust her. They trust her emphatically, as they should, right? So she's built this practice. And, instead of being in a tent, I had the opportunity a few weeks ago to see her latest space. And wow, just the amount of dressings, the light, kind of near surgical type lighting in the room that she has. And people are lined up to get care from her. And this is a population that isn't getting care anywhere else. They don't trust anywhere else, and for good reason, right? Because they are disenfranchised they don't have a family doctor largely. They don't have they don't trust hospitals. They've been treated very poorly in hospitals, and so this is the only place that they can get care. So when they talk about closing safe consumption sites, they're talking about cutting those people off from family care. Now, I get it that there's probably an element of the politics of this that honestly, and it's going to be hard to listen to, but this says, who gives a shit, right? Who gives a shit? Who gives a shit about those people, right? And I think that's true. I think there is, we'd be lying if we didn't say that, because I think there's part of the population that are in this country that say, those people are a write-off. So why do I care about them? Well, I'm not going to tell you to care about them. We can't tell someone to care about somebody. But what people do care about is EMS waiting times when you're waiting for an ambulance, right? People care about how long you're waiting in an ED, right? So people care about cost, taxes, right? Those are 3 things that I think every Canadian will care about, right? If grandma has a heart attack, they want the ambulance to get there pretty quickly. So what's going to happen, it's not rocket science here. If you get rid of that nurse in that community, those people are not going to automatically get well, right? They're going to need that care. Where are they going to go for that care? Well, they're not going to run to the hospital, I'll tell you that. And that's even worse, but they're ultimately going to end up in the hospital, and they're going to end up much sicker than they were when she was giving that care on a daily basis, right? So instead of just getting a basic wound care, they're going to end up with sepsis, and they're going to end up in an emergency room. How are they going to get to the emergency room? Probably by an ambulance, right? And then instead of getting just basic wound care, they could have an ICU admission to treat their sepsis. So instead of a $20 visit in a safe consumption site, you could be talking about $4,000 a day in an ICU unit.
Yeah, I think where you're going with this is that it is actually going to help and save money to have it. You're almost going towards the business case, but I think there's also one thing that you said earlier that I think is very important to really note. People that come to these places do not feel comfortable going elsewhere. Right, and that part is very, very clear. I mean, I still remember, I think like we have a public health place in Toronto near a hospital where I used to work, and I went there trying to pick up some of these harm reduction skills, and it was so upsetting because when I spoke with some of the staff that worked there, when somebody was medically sick where they had to go to the emerge, they almost had to beg the patient, please go, because all these patients have horror stories, right, with how they were treated, and there's something about the medical establishments where it's very sterile for like infections. It's also very void of like overt like compassion. Structurally, they're not designed 100%. As warm and friendly places. And when I visited you, I don't know, it was 2016, 2017, whenever it was when that place was there. I almost wish they had like a place, because it was a place where I think that people could use in one place and they could hang out at another place. Yes. And it was in the fall or the spring, right? And wouldn't it be nice to have a place where people can go? I don't know why. I remember that just like we should have places where people can get like manicures, pedicures, like anything to feel human, right? Like anything to like like where they can say like, you know what, I care about you as a human, I love you, all that stuff. When you're talking about this nurse, and I apologize if I've met her and my memory is off, but I think like we need people like that to create spaces, right? Or to be part of the team creating spaces so these vulnerable people can get the care that they need. And hearing you speak, it's you really believe these safer consumption sites are essential. They're essential to keep these patients alive. And one thing that's making it hard to keep them open is everyone's confusing that with safer supply.
Well, they are, and everybody is confusing that with enabling drug use too. So there's a couple other elements of this. So I think people think the general consensus is that these sites are encouraging substance use, right? And if they shut off these sites, well, they won't use drugs anymore. And ironically, they're using the argument of, well, they're too close to schools, they're too close to this. Well, okay, so here's another element of it. You close these sites. So in these sites, and we're going to get to a picture of one of these sites next here. So this is what they look like inside. Okay, it hardly, I don't see it as a drug den, but it's a sterile environment, super bright, super clean.
Very, very medical.
Very medical. And there's always a nurse there supervising. You've got a lot of lights, you've got a lot of mirrors, and you're trying to find a vein, and that can be very challenging for people that are IV drug users for a long time or even for a short time. And you've got a nurse willing to help you do that and making sure you're well afterwards. And so this is the inside of like a schematic of one of the safe consumption sites. Ironically, one that was only open for a few months in Windsor and had to be closed.
So why'd it have to be closed?
Didn't have funding. It didn't have sustainable funding, and there was a lot of political pushback about having this site in Windsor. But if you look through here, you see that there is this is very much reminiscent of a medical office as opposed to a drug den or a bar equivalent, which some people make that comparison. So you've got accessible spaces, you've got examination rooms, you've got labs, you've got offices for caseworkers to work in. And then you've got the stations where people are consuming their drugs. So And so this is the stuff this is what it actually looks like inside. So it's not, and for the people that think that we're handing out drugs, well, the only thing they hand out when you get there, this is what you get. You get a clean needle and syringe kit.
I was shocked when you told me that certain healthcare providers thought that these kits included drugs to use. I was wild. I just like, and these are like healthcare providers. Right?
I'm embarrassed to say that
I was like wild.
There are still, I'm not calling anyone out because I'm happy that they're willing to at least.
Well, they're curious. They want to know. They want to know, and we want people that want to know.
And they come to trainings that I give, and 90% of my trainings are voluntary, so I'm happy that they're there. But I am still shocked. Every year there is at least one physician that works in an inner city hospital that is surprised or is quizzitive about the narcotics that are provided in these kits. So if an inner city hospital physician is there, I don't blame anybody from any part of this country or any country that thinks that. So if they're out of touch of this, then I think everybody thinks.
How's anyone in Parliament going to know the nuances if you have a healthcare provider providing frontline care who hasn't been taught it or hasn't been exposed to this knowledge?
Absolutely, right? Yeah. And so that's the reality of it. Now, so that we were talking about the tent in Moss Park. There you go. So that is the actual tent in Moss Park from 2017. And these are three of the pioneers, Matt, Zoe, and Nick. I think mostly Matt and Zoe were involved in starting that, but Nick is a huge harm reduction guy. And these were the people that started something that was quite illegal in the beginning, right?
Yeah, no, it was wild because, they at any point they could have been charged. They could have done whatever, but it was something where like back in 2016 when these overdoses were coming, people really weren't listening. People were treating. I don't want to say me because I'm not that important, but I felt like Chicken Little. I felt like people were treating me like Chicken Little when I was. That's how I'm getting upset because you have all these memories, right? You have all these memories, and there's certain treatments that are going to help, and it was almost like the deaths hadn't reached that threshold, right? Because if you look at the overdose deaths in Ontario at 26, 14, 15, that's when they start going, and then they go. But we felt it right there. Right? We felt right there. I still remember you telling me it was like something about like how it's like all of a sudden you have people that use drugs all the time, and then on these random shelter shifts, 3 overdoses, 4 overdoses, right? And in the hospitals you don't hear about this. I remember one of those days I literally had like 3 rooms beside each other where I was going to see people who'd overdosed and come in. Nobody wanted to talk to me. Nobody would even talk to me. Like nothing I could do. I was just like, how can I help you? What do you need? They're just like, what? It was just like a. It
literally went from one overdose a day to 8 overdoses a day in a period of about 3 months.
God, it was just wild, and then and luckily, like the same thing happened with not the exact, like it's a metaphor, but with HIV in the 80s. It was just like all these. It was people that were frontline, that were like activists that had, and I heard rumors. I don't know if this is true. It was only after a few politicians' family members got affected that all of a sudden some of the stuff shifted and changed in terms of policy. But I admire people like that because I don't have the guts or strength to do something. And also, I without the data, I always don't have that belief around what's going to work or help. The thing what they were doing though that doesn't need data is the humanity.
Absolutely.
Right? Like there's something about that humanity that you don't need data to implement that.
Right.
Some of the nuanced stuff around like say if we do have safer supply in a way where it's like less potent or more predictable, like fentanyl, this, I think it has to be delivered in a way where they're properly evaluating it, when they do it. But you can't, like, if someone's going to be using, why not have a place that they're going to be able to use safely?
100%. And Zoe and Matt put themselves out front and did this and have done this for years and years and years. They're still doing it 8 years later in one form or another. She's a leading advocate for this, and she put herself front and center. So very very proud to consider her a friend of mine, and hopefully she considers me a friend too. Okay, so that's kind of.
Have we covered safe consumption sites? You think?
To a point. So we're going to circle back to it a little bit here.
Got it.
But I do want to define what safer supply is too. So I just want to pull that together at the end. I'm not talking about, this isn't about safer supply, but I just want to make sure that people know what safer supply is. So safer supply is a pharmaceutical grade of opiate that is provided to people. It's got a couple names: safer supply, safer oral supply, prescribed alternatives, and PSAD, which is the public supply of addictive drugs. And you can imagine that was come up with somebody who probably doesn't fall on the left side of the argument of it. But so harm reduction by offering safer supply. So we don't consider this addiction treatment, right? Is that fair?
Yeah. It all depends. I don't know where the wave has gone now, because I've heard people use metaphors like it is. Historically, when it came out, it was really seen as an immediate response to the overdose crisis, just to try to keep somebody alive and try to reduce their fentanyl use. And it was implemented using a public health lens as opposed to a substance use treatment lens or an addiction treatment lens.
Right. And so one other quick thing about this is people think of methadone. Oh, I'm 100% in support of safe supply. I've heard this 100 times. I literally have heard this 100 times. I absolutely prescribe methadone, so that is safer supply.
So OAT is, it's absolutely not safer supply. So when you learn about addiction healthcare, what you want to do is you want to sort of reduce the harm. And if you know somebody who's injecting opiates, they usually have to inject 4, 5, 6, however many times a day. Same thing with smoking. And so the reason that we use things like methadone or buprenorphine, or now in Canada, slow release oral morphine, Canadian, you can't use that in the States because it's illegal, and then the Drug Enforcement Agency will take away your license. But in Canada, we can use Canadian as an opiate agonist treatment. It has a very, very long half-life.
Right.
And so over the course of the day, you won't have the withdrawals, right? And I don't know if we've talked about it here, but I talk about a lot that, when you start using the drug, the high feels good, the bad, not so much. The more you use, the high is smaller and smaller and smaller. And the bad, the withdrawal is bigger and bigger and bigger. And things like methadone and buprenorphine, you only have to take them sometimes once a day. A lot of times the withdrawal is covered for the most part.
Yes.
And just like the same way you would move from injection or to smoking, although that's controversial which way you'd go, to sort of swallowing. You just want you want to change, or from snorting to swallowing a drug. You'd want to move from things that have a shorter half-life to a longer half-life.
Right.
And so that's the thing. And the data is very strong for methadone in terms of reducing transmission of infections, for reducing criminality, and for keeping people alive.
Yeah, absolutely. So this is now talking about the politics of this has gotten so extreme that vending machines, which is a dispensing method of clean supplies, not safe supplies, but clean supplies, which has been evidence-based since the 1980s. These vending machines have been...
Oh, you're talking about...
Vending machines.
Oh, you're talking vending machine for
kits, for clean needles.
Oh, so I completely missed part of the conversation.
We're going to have to get you to wear your glasses when we're doing this thing.
Yeah, the glare.
Yeah,
the glare.
So that's true.
But did you want to say anything else about safer supply?
No.
Okay.
I don't want to fall down that rabbit hole too far. Unless you wanted to say something more.
No. I just wanted to clarify what OET. I just went on a thing about what OET is.
That's
right?
good. That's good. I think that people get the big picture of just what it isn't is really what I wanted to get into. So,
got it.
So this is kind of just an example of where the temperature of the conversation is going. So vending machines, which I'll show in the next, there's a picture of a vending machine, a very fancy one that on the left that is, and then our kind of ratty looking one that in a hospital that I work at in downtown Toronto. And these just they don't have narcotics in them. As I said, these kits don't have narcotics in them. And but this is where people can get kits. Now, there is evidence since the 1970s, 1980s, and we're going to, at the end, you'll see a link which shows in the description, you'll see a link which shows the studies of this, that these have been used in France since the 1970s and 1980s to reduce things like, was it Hep C in the 70s too?
Yeah, so I don't know the dates and the timing, but definitely infections that are transferred via bloodborne methods. But even, sometimes when they have smoking kits, those can also help, especially people get cracks and stuff in the...
Oh, absolutely. Definitely the smoking kits help.
Yeah.
But here's where the politics politics have gotten. So this is a Nanaimo, which is a British Columbia. I think it's on the island. Is it on the island? My BC
God.
expert. When you're taking your helicopter, are you flying over Nanaimo or not?
God, I have to look at them. I'm so ignorant.
I think it's in. I think it's on the island. Anyway, it's in beautiful British Columbia.
Beautiful.
Absolutely
British
beautiful.
Columbia.
But this is a real picture of their emergency room bay in August of 2024. The same picture in September of 2024.
It's not the same picture. Something's different.
Something is different. Very astute.
Is that the hydromorphone vending machine, or is that the clean supply vending machine?
That is the clean supply vending machine.
Okay.
And it's been removed because.
Why would it be removed? It's such a good idea.
Well, because the consensus is that that children will start doing crack, and grandma might start doing crack if she saw a vending machine there, and it was so tempting for her.
But didn't they already figure this out with condoms? Did we decide condoms for all? Like.
We haven't decided that because they don't like the location of it. And so
honestly, I mean, this is where no, think about it. Like, say hypothetically, I feel like I'm mansplaining to somebody right now. Like imagine you're somebody that used drugs, right? Maybe security's been mean to you, rude to you. Maybe you've been beaten up at different points. Like if you don't have access to that, and if you've been kicked out of hospitals because you've used drugs, you're there because you have chest pain, a heart attack, you've already been kicked out. Like, there was a place that I know where they would only give out one kit at a time, and you had to ask the security officer for it. Mm-hmm. And then once you got it from the security officer, they would follow you everywhere you went. I still have patients that tell me, every time I go to this hospital, they don't let me use the bathroom. They just follow me wherever I go.
Absolutely. And
so you have to, if you want to spread it, if you believe in it, you have to have it at the front like that.
Yeah, well, you have to have it. It doesn't matter where you put it. They've removed it. They didn't move it somewhere else. It's been removed.
Oh, so they have no access to safer supply? Oh, sorry. What was the term?
These are clean supply vending machines. And this has been removed. This has not been moved to another part of the hospital. It has been removed because there's an election going on in BC, and it's so politically charged right now.
Oh, so is it because the party in power wanted to stay in power, they took it away, so it looked like they weren't providing?
I mean, you would have to ask them that, but one could take that meaning into it. I certainly. I'm making stuff up because I don't actually know why it was put. I didn't know it was put there and then removed because I don't live there. I don't work there. Yeah, no, neither do I. But this is real, and this was sent to me by one of my colleagues, one of my harm reduction colleagues in BC, and these are real pictures. Okay, and. So, and just big picture stuff. I'm not going to get really deep into this.
I did a little bit though. I took but this is bread and butter. This is bread and butter addiction medicine training.
Yes.
Where you get people to move, and this is back from the heroin days and back from the times where the prescribed drugs, the prescribed pain medications were causing problems. These were the two go-to drugs. Methadone with the most evidence, buprenorphine first line due to its safety profile. And in Canada, we do include slow-release oral morphine because it was a really well-designed RCT that showed it was non-inferior to methadone.
Randomized controlled trial. Is that what an RCT stands for people that don't know? I think
so, yes. Yeah. So they take one group, but it was also a non-inferiority. So they weren't trying to say, hey, does Estron work? So they gave a bunch of people methadone, gave a bunch of people slow-release oral morphine, and it was non-inferior in terms of the overall response.
Okay. And one other, we're just covering the big harm reduction bases here, which is managed alcohol programs.
Yeah.
So these are sites that help people that have a severe alcohol use disorder.
Alcohol use disorder.
Right. And a couple great references in our community is the Shepherds of Good Hope, I'm going to really mess up that name, of the Kwai Key Win Center in Thunder Bay, and Seton House. So these are largely any individual that I've been able to send there is somebody who is not drinking alcohol, drinking a form of alcohol, but they've switched to what we call.
So these are actual.
These are actual.
Myths.
Well, I don't know.
The second one's a myth.
The second one is a myth. So
the first one isn't. So I think we've got
I may fix this slide by the time people see it. But so the myth being the government is.
We're getting confused. They're going to get.
No. The first one is a myth, right?
Yeah.
Yeah. No, they're actually they're both myths.
Oh, okay. So people aren't always intoxicated.
Correct. So.
Oh, good. And then
first of all, I just want to clarify.
But you are giving people free alcohol.
No, you're not. You are not.
Managed alcohol, they get it every hour. They get like a cup.
They have to pay for it.
Oh, I did not know that.
They absolutely have to pay
I did not know they had to pay for it.
Yes, they do.
Like what, like $1 or $2, or it's like part of the.
They have to pay
a token.
I think it's about $9. I think it's $10 or $12 a day that they have to pay.
I did not know that.
Yeah.
Oh my goodness.
Yeah, and that's sometimes a barrier, right? So you have to.
Yeah.
So it's not free alcohol, and they're not serving intoxicated people. Once you've reached the level of intoxication, then you're cut off for the next hour. So I guess the point of this is not, for people that are just love the alcohol. This is for people that have already started drinking hand sanitizer, rubbing alcohol, and what we call non-palatable.
Yeah. So in I don't know what city, I don't know if it's Sudbury, but a colleague of mine was saying that they had about 12 people, maybe it was 20 people, I don't know the exact number, who were going to the emergency constantly, right? In the context of alcohol intoxication or withdrawal. And some of you may know this. In terms of the hospital setting, alcohol is probably the most common thing that we see.
Absolutely.
And withdrawal from alcohol, especially if you're drinking like a Mickey or 2.6 of hard liquor a day and then you just stop, you could have a seizure and you could have die. And it's a very, very real and severe risk. And so these people were going there so often to the hospital, they had a business case that, hey, you know what, if we just rent them a home with a bunch of rooms and give them a little bit, at least they're having palatable alcohol, the amounts are a little bit more contained, and then the emerge visits go down. And then all of a sudden the hospital visits dropped dramatically. But this is a treatment that is not designed for the 16-year-old that's just starting to drink casually, right? This is designed for the one where it's already had a devastating impact. And it's almost, and I don't know the right way to say it, it's almost like a palliative-ish outcome, right? Where you're just trying to reduce sort of those harms. The problem that, and I almost don't feel comfortable talking about managed alcohol because I'm an outsider. Right, so I don't actually work in one of the programs. I'm not their front line doing all those things, and that's also why I'm hesitant to talk about some of these safer supply things. I'm comfortable talking about the times that I have it in my practice. I believe in order to have a managed alcohol program that works, the second somebody wants to stop, you give them a pathway out, and also every now and then you find a way to have a dialogue where the person's sort of with it. So not completely high, you're not completely withdrawal, and they could really explore what the values are and what they want. So it's not like that unrestricted compassion with unlimited alcohol and you can drink until you die in front of me. It's like, what do you really care about? What's important to you? And if there's anxiety, if there's trauma, if there's personality, if there's whatever, offer them the best possible treatment. I mean, maybe I'm being more ideological here, but I think it's important to talk about this and not being an expert.
I think what you've touched on there is everything that we're talking about, which is harm reduction, right?
Everything, yeah, everything.
Yeah.
It's just, and it's the nuanced and complex.
It's all that, and I think the part that I really wanted to talk about now is about why any of this matters, right? Where we hear a lot of people saying, well, all somebody needs is a good paying manufacturing job and everything and a treatment bed, and then they will be better, right? Well, first off, we're not giving them the treatment bed because we don't have a detox bed or a treatment bed for them. That's one thing. We'll put a pin in that for a moment. But let me tell you something that I can speak of from personal experience is that everyone who probably watches this or has watched a couple episodes knows that I'm somebody with lived experience. But more importantly, I was so disenfranchised from the system. I was the subject of code whites. I wouldn't talk to anybody. I wouldn't join any program.
So code whites just
code whites are for people that are rude, speak impolite sometimes to the healthcare providers.
I should be smiling. Oh my goodness.
Or they feel threatened, or
it's where they call security. Like the nurse calls security because they're scared.
They're scared. Somebody's scared.
Somebody's scared.
Everybody's scared. Everybody's scared. And people love being scared of substance users, frankly. And and this is something we're working on. But it's real today as it real it was when I navigated it 10 years ago. And the point I wanted to emphasize here is that somebody that's at that point, and we're all talking about fixing these social problems, and I hear just horrible language, and I'm going to use some of it, where they say, what about all these zombies walking around on the street, right? I hear that. You've heard that.
Oh, I hear it, yeah.
Yeah, we hear it on YouTube, everywhere else, and it's like, everyone that you're identifying has an unmet need in their life, right? I'm not going to generalize, but I'm going to say there's an unmet need. I don't know what that need is. Maybe it's mental health support. Maybe it's housing. Maybe they've got an arrest warrant. In my case, I was on Crime Stoppers most wanted list and had 29 criminal charges. So that's a lot of an unmet need. And we don't talk about harm reduction being a gateway. It's not, because that implies that you got to go beyond it. But, for the purposes of this discussion, I'm going to stretch it a little bit and say it was a gateway for me, right? And it allowed me to see that there was a future, right? It allowed me hope, and it allowed me to connect with people again because they didn't judge me and they took me in when nobody else wanted me. I was okay in harm reduction. Nobody kicked me out of harm reduction, right? I didn't even know it was a program. And if you shut down that harm reduction, you are shutting down that population. And, even if you don't care about the people dying in the streets, I think you care because you don't want to live in a city where people are dying in the streets. You're talking about kids finding needles in playgrounds. Well, if you take away the places that they can use substances, they're just going to use the substances in the playground. So you're cutting off your nose to spite your face in these situations. So I think it is just super important that we really think about what we're trying to accomplish here when we start closing down programs that can provide options. And all these programs are predicated on the fact that there should be, as you spoke of, a vehicle to get treatment, a vehicle to get well. Well, we're not there yet, and that's the big problem. The 9 out of the 10 patients that want to go into residential care that day can't get it. So you have to, if you care about this problem, if society cares about this problem, then that's what we need to do first, and along with harm reduction. So once you take care of those 9 people, I think everyone is going to be really shocked. And this is something I do every day, is help these folks that come in from overdoses in an emergency room in a downtown center. So I can speak about my experience. I can't speak about anybody else's, but I can tell you that a lot of those folks want to get well. And if you offered them a future, if you offered them hope, if you offered them, a pathway to wellness, whether that's mental health support, whether that's housing, whether that's a legal aid clinic, I think you'd be shocked how many people took that step, right? And we don't have it yet. So before we do anything, put that in place. That's my end of my rant.
Yeah, no, it was rant. I agree with a lot of the things you said. And I think there's a few things that are essential sort of take home points. And I'll even leave the pathways to treatment, for people that want it, a little bit aside for now, because you touched on something so important, so prevalent, so nuanced, that some of the rhetoric doesn't come close to capturing. At first, get them a treatment center, get them manufacturing jobs. You've been in states where there's nothing any healthcare provider could have said to help you in some way. It would be like, leave me alone, fuck off, like all that kind of stuff. And I still remember, I think it was Tim, right? Because I did a lot of training in motivational interviewing and the different therapies, and Tim almost framed it as
this is Tim Guimond, one of your
Tim
mentors.
Guimond, very
super
skilled,
smart guy,
very skilled therapist, psychiatrist. He has this skill where when you watch him with certain patients, he can win them over in such a way where the message is heard, right? Whereas some of these people or states that you've been in, or I've been about other things, nothing as serious as this, but where even if you're getting the right message, you're on a state. But he has a skill set around that. And he taught me a lot about psychotherapy, and he inspired me to want to be a good therapist. And for some of these patients, the usual motivational interviewing stuff doesn't work. And he was saying that, when people are in such a dark place like that, sometimes they don't believe they're worthy of living a healthy life. They don't deserve to be happy. They don't deserve to have meals. They don't deserve to have a home. And it's not in the realm of possibilities. And when you do harm reduction, right, when you give somebody a needle, what you're telling them without telling them, and is what they're telling themselves, you know what, I don't deserve to get an infection, right? I don't deserve to have an abscess here. I don't deserve to be in the emergency department. When you're giving them palatable alcohol, it's like my body doesn't deserve to have rubbing alcohol in my system. It doesn't deserve to drink it. I'm better than this. And once you get somebody to the point that the person believes they're worthy of love, and maybe that's a little strong, but then the motivational interviewing could work. Then some of the therapies can work.
Personally, what worked best was to get into a supportive housing environment where I had workers 24 hours a day to help me, to talk to me, to any problem that I was having, because I was still using substances when I was there. They were there to support me, right? And that's the type of highly structured support that not judgmental, but someone to talk to, right? Yeah. And if I started getting, amped up about something, there would be someone there to talk me down from it, and not a security guard, but somebody that has been trained to help people that are in distress and working with our population. And that's what's so critically important. And, the role I have now, I haven't worked in SCS for 7 years, but I have the honor of working with some of those same people, and they are trying to send the population, because we still have the, whether it's an MRI or a CT scan, they still need those services, right? Or, sometimes a surgery, sometimes, and that population has a very understandably challenging time navigating those sites. And I'm so fortunate to be able to help sometimes, try to help with mixed results sometimes, but I do my best with it to try to create that, kind of continuum of care, right? Where we built this community. And that's what I'm so afraid of losing. I'm so afraid of losing that, right? That's so important. If we lose that, then, I don't know what happens next, right?
You really see that as the best way, maybe even the only way to capture these people who need or want or would benefit from that help, that aren't getting that help, that aren't showing up at the hospitals.
They have fallen through every crack you can imagine in life. Nobody wants them, and it's so relatable to me, because nobody wanted me except the police, right? Those are the only people that wanted me. And so you know what that feels like, and so and when you're connecting with someone else that nobody wants, or they feel nobody wants, it's a visceral connection, and you want to try to help. Right? You want to try to help in a very limited resources that we have. So I think that little bit of a gateway, it's not housing for people. It's just a little bit of a connection where, if they need an antibiotic, if they need mostly wound care, that's one of the most primary care things that they do there, or a dressing, or anything that they just very basic medical needs, because they can't navigate any other healthcare system. And I'm just so afraid of what happens next.
So you're scared that you close the supervised consumption sites, and then no one's going to help these people, and they'll pass away.
I'm scared of that, and for all my friends that or all the people in our community that say, okay, so what?
So what? People say, so what about the consumption sites?
So what about people dying? I know that's not something you want to hear.
I would never say that.
Of course you wouldn't say that. Nobody probably watching this will say that, but we're all fools if we don't think that.
I think I think it's, maybe people just don't realize that the pathways for more people to become dependent and lose their lives is open and full. Because the rates wouldn't be going up, people would die, then we'd be done, right? But it's not the case.
It's not like that. If you don't offer those supports, you don't offer those basic supports in society, then you're going to get a growing population of people. But even beyond that, if they're filling up our emergency rooms instead of a safe consumption site, if they're openly using drugs in the community, then that's going to be a problem for people. These safe consumptions always have volunteer staff or paid staff that are cleaning up every used needle on the street is being cleaned up by people. You get rid of those safe consumption sites. Who's cleaning up those needles now?
And the part for me that I wish there was a way to have you can't have that dialogue with what we saw like at the beginning of this talk. what's the magic sauce? What are those magic elements? Like, do you have to have food sort of at the front? Are there a certain number of hours? Do you have to make sure that you guide people like not to yell or not? My point is, it's like a classroom, right? Like, how do you make a classroom work? There's all these soft skills where when you have a great teacher, it runs. But if you look at the entire school system, not every classroom is the same. And I can almost imagine the same thing happen with these supervised consumption sites. I don't know what the job turnover is like. I do know from detoxes, caseworkers, stuff before these consumption sites were readily open, the turnover was very, very high because you had people that they didn't have the support structure to excel at their job. I mean, we find our jobs drainable. We have a lot of support structure, like I think compared to other places. I agree with you 100% that we need places like this to capture the people the system isn't getting. And the way that I've seen other things rolled out, like when they roll things out in certain shelters or certain other places, there's certain basic principles that aren't being picked up or adhered to.
Yes.
And things that you would say are obvious aren't, like just like that locked bathrooms and locked doors, right? If you have someone who's heavily using, you need a way that you can access them or have conversations so that when they use, someone's able to revive them in some way.
There is one other point that I do want to cover in fairness to the government, which is suggesting it, and I am trying to be, pragmatic about this.
In fairness to our provincial government,
Correct.
who's saying to shut down these programs?
Correct.
Okay, good. I didn't see that coming.
Yeah.
Okay, let's hear it.
So this is the heart centers, right? So these are the homeless addiction resource and treatment centers, I believe is what HEART stands for.
I didn't know that, yeah.
And this is a $387 million program that the provincial government is putting in. And so the controversy, and I don't think anybody on the surface has any issues with the concept of offering this as a adjunct service pathway for people, right? I don't think that anyone has any problem with that, except the government has put a condition in there that you cannot dispense clean supplies in these heart centers.
Given the evidence for harm reduction kits, it would be highly unethical and bad medicine not to provide.
Correct. So that's the one issue with it. The other issue with it is I believe that where they're kind of going is a bit of an Alberta model. And I know there's a lot of different opinions about everything that seems to happen in Alberta, but at least Alberta is trying something. But let's look at the money. I think Alberta has spent like $1.7 billion, that's with a B, on their...
How do you know this? I love it.
Their program so far.
Yeah,
now, and they have 1/5 the population that Ontario has. Okay? So you're talking about a $387 million program for a population that's 5 times the size of Alberta. So you could tell right off the surface.
But they're not using a HEART model. They're probably doing something else, right?
The Alberta model is not exclusion of
I heard
reduction.
they have these narcotic treatment center. I don't know what they're called exactly.
Well, they still have safe consumption sites.
Yeah, the safe consumption sites, and they have injectable opiate agonist treatment.
Yes, they do. So there are still programs where they're harm reduction friendly in Alberta as well. So I think they're it's a bit of a poor man's Alberta model where they are talking about housing, they're talking about jobs, and I think it's a little bit ambiguous as far as where the even the treatment beds that they're talking about, because I don't believe they're funded with that amount of money, because we know how expensive it is for treatment beds. But I think the issue is a lot of advocates say, okay, bring on your HEART models, that's fine, but bring it on in addition to the safe consumption sites, not at the exception of them. We're open to this dialogue, and I think we should have this dialogue. And that I just wanted to acknowledge that trying something is not a bad thing. And Alberta's tried a lot of things, and a lot of them, their overdose deaths are down. I know they're down in a lot of places.
It's so hard for me to interpret the data. Like I don't even I read, and I don't know what they're measuring or any of that stuff. But you're right. Recently, the overdose deaths are down.
Dead people from overdose deaths. That's what they're measuring.
Yeah, and it looks like it's going down.
Yes,
it's
they're
good.
down.
Yeah, it looks like it's good.
Yeah. So, I think that kind of brings this all together. And
but I do think I'd love to find a way just to recap, just 'cause I think there's key points here. I mean, other than the fact that, the biggest point really is that if we don't help people, that the current system is failing, who's gonna help them? And the safer consumption sites are a way to capture those people, so there's a chance, right? So that part is absolutely true. But I think the part that I want listeners to know and think about is the definitions, right? Because you see words, and it takes me reading a whole article to know what they mean, right? And from what I've heard, and maybe I'll just sort of summarize, a safer consumption site is a place that people can go to. They'll get access to supplies that'll facilitate the usage of drugs, but not the drugs themselves.
Correct.
And there'll be overdose workers there. There'll be like maybe primary care, so medicine might be there, just for wound care might be there, things around that wraparound services. Sometimes there's things like things that help people get on social assistance or whatever that thing as well. But these are the sites that people come to use. The term safer supply refers to the prescription of narcotics in levels that are trying to reduce the whatever illicit drug supply, or
Correct.
to have a more predictable source of drugs that are there. And the funding for that is very sort of, you can call it complicated, but that's what that is. There's opiate agonist treatment, which is similar to safer supply in that it's an opiate, but these are usually long-acting medications, and these are ones that there's very good data to suggest that for some of them they reduce use, some of them they reduce death, they reduce crime, they reduce transmission of these infections, those kinds of things. And the prescription of hydromorphone, it's still in the early stages of data, and there's some nuances to it that are definitely not captured by the political rhetoric, but are also not fully captured in the nuanced discussion between experts in the area. And then the last thing that you had was the managed alcohol program,
Right.
Where I almost want to say we're not experts on any of this stuff, right? But we know lots, and you know lots from lived experience and from other stuff. But the managed alcohol is really for people with very severe alcohol use disorder, and it's I don't want to use the wrong word. It's almost closer to almost like a palliative kind of
Sure.
approach than to move people towards abstinence in some kind of way, depending on the person. So I think those were the key definitions.
those
And the
are.
hope is that like every time you see somebody talking about something, you spend a little bit of time reading through the subheading to figure out, does the person know what they're talking about? Are they lumping stuff together? All that kind of stuff. And it means a lot to me that we got to do this together, and you shared something that you deeply care about. I mean, you care about everything that you do, but your facial expression sort of gave you away, right? In terms of how frightening this is
visceral
for you.
journey for me. I mean, this is which sometimes you could say I'm not being objective about it, and that's probably a fair critique. I mean, I obviously
you're being, but it has that added level, right? Because you do a lot of direct, I don't know if you'd call it clinical care. You're at tons of tables where they develop policy on different things. People trust you and confide in you in the pros and cons of things that are being delivered and administered. And in a previous life, you were the type of person that these programs were trying to help and save.
And they did.
And, well, I almost feel like it was like this magic thing that occurred for you, right? But you're right. It was very close to the safer consumption sites and the supportive housing than anything that people would define as traditional addiction care.
Right.
Right.
It was 100% nothing to do with traditional addiction care.
And what value they got in return for those couple of years that they helped you out. Oh my goodness. And all of these people, I believe there's that potential, and I would love to get that value in return. And we're lucky because the value return could have just been on your life, but it just keeps going in all these other ways from what I've seen, right? And I think I love the fact that you're at these tables. I love the fact that you're willing to go on these emotional roller coasters, because I think in everyone that we work with, there's that potential for someone to have an impact just like you are continuing to have.
Well, thank you for sharing that, and thank you for sitting down and having this talk.
Yeah, thank you. I'll see you soon.
Thanks.